Hello, I'm Lucy Mailing and I'm an S27 in trauma and orthopedics. Necrotizing fasciitis. What is necrotizing fasciitis? It is a life-threatening infection involving the subcutaneous tissues and fascia. What it isn't is a flesh-eating disease. It is caused by bacteria or rarely fungi, and these do not eat flesh, but instead secrete toxins which cause tissue necrosis. Don't believe the Daily Mail. What causes it? Bad luck, mainly, and a sprinkling of microorganisms. It can be classified into 4 main types. Number 1, which is the commonest, is polymicrobial, which means a number of different bacteria act together in synergy to cause overwhelming, life-threatening infection. Number 2, monomicrobial, which is typically caused by a group A beta hemolytic strep or methicillin-resistant Staph aureus. The group A strep type is commoner in healthy patients, whilst MRSA is seen more often in poor specimens. The third type is caused by marine organisms. And the rarest, type 4, is a fungal infection. This is almost exclusively seen in immunocompromised individuals, such as diabetics and intravenous drug users. Necfash can occur in anyone, but certain risk factors do predispose. As mentioned, these are any cause of immunosuppression, such as diabetes, cancer, obesity, IV drug use, as well as abdominal and perineal surgery. Necfash is more commonly seen in older adults. It's extremely rare in children. So, how does the patient present? They will be very unwell, often profoundly septic and rapidly deteriorating. Locally, there will be disproportionate pain, and this helps to differentiate it from simple cellulitis. In the later stages of disease, the affected tissue may be discoloured, blistered, swollen, sometimes even black with local gangrene, and on palpation, it will be very tender. There may be crepitus. This suggests gas in the soft tissues or subcutaneous emphysema, which is always abnormal. As you can see from these images, necrotizing fasciitis can affect any part of the body. If it affects the perineal region, it is called Fournier's gangrene, named after a French physician. I remember this by the mnemonic, those who fornicate get Fournier's. So how is it diagnosed? It is diagnosed clinically with the aforementioned symptoms and signs. But there are some adjuncts to help differentiate this from other types of infection, such as cellulitis of the skin. This table shows the Lurinek score, or lab risk indicator for necrotizing fasciitis. I used to think Lurinek was a physician, but I only recently learned it's an acronym. It uses 4 blood parameters to predict the likelihood of nec fash. Number 1, CRP. This seems to be the most important feature, and a value of over 150 scores 4 points. Often, I have seen these patients will have a CRP in excess of 300 or 400. The other parameters include hemoglobin, white cell count, sodium, creatinine, and blood glucose. A total score of 6 or more has a positive predictive value of greater than 90%, meaning that there is more than 90% chance you've got the diagnosis right. It's also important to test the patient's lactate. As I mentioned before, they may be profoundly septic, and lactate is a good indicator of end organ perfusion. What is this test? This is another adjunct to diagnosis and is called the bedside finger sweep test. A small incision is made at the affected site. A gloved finger is inserted down to the fascial layer, and 3 things are examined. Number 1, the lack of bleeding. Number 2, presence of dishwatery fluid. And 3, the ease of finger dissection. Usually, the fascia and subcutaneous tissue should be fairly adherent to one another. But in neck fasc, the infection spreads along the plane of the fascia, dissecting it from the overlying subcutaneous tissue. In reality, I haven't seen this done because most patients won't let you stick a knife into them whilst they're wide awake. There is no role for imaging in necrotizing fasciitis, as this will only cause delay. However, if somebody has already ordered plain radiographs, you may see subcutaneous emphysema or gas in the soft tissues. In some swanky hospitals, a frozen section of histology can be diagnostic, but this isn't often readily available on the NHS, and it's not acceptable to delay diagnosis. The differential diagnosis of early necrotizing fasciitis includes cellulitis, and other differentials include a superficial abscess or collection, deep vein thrombosis, compartment syndrome, peripheral vascular insufficiency, and gas gangrene. Gas gangrene presents in a similar way. And in fact, both belong to the umbrella term, necrotizing soft tissue infection. One difference is that gas gangrene is caused by Clostridia bacteria, usually Clostridium perfringens. And instead of causing destruction of the fascia and subcutaneous tissues, it causes myonecrosis, i.e. destruction of underlying muscle. So how do I treat necrotizing fasciitis? I treat this as an orthopedic emergency, meaning I initiate treatment as soon as possible. I commence high-dose, broad-spectrum intravenous antibiotics following my local trust policy, and ideally, I discuss this with my consultant microbiologist at the earliest opportunity. I take this patient to theatre, day or night, for debridement of the affected tissue. Antibiotics alone will not cure this infection, as antibiotics cannot reach necrosed tissue. Note that when I mentioned debridement, I said debridement of the affected tissue, and I do not use the term radical debridement. Radical debridement refers to the excision of an entire compartment and is a term that's used commonly when talking about bone cancers. It may be that the whole compartment needs to be excised, but not always. Instead, I prefer to say appropriate debridement. That is, taking away all necessary diseased tissue, but nothing more. That said, this can be a life-threatening condition, and the primary duty is to preserve life. So occasionally, an amputation is needed, and this really is the end point on a spectrum of debridement. How do I tell how much tissue to take? I can use the 4 C's: colour, contractility, consistency, and the capacity to bleed. Dead tissue may look grey or dusky in colour, and sometimes black. Living muscle contracts when stimulated with monopolar diathermy, but dead tissue does not. The consistency of the tissues may be mushy or easily sheared off. And finally, dead tissue does not bleed when cut. These 4 C's are also helpful in the debridement of open fractures. Note that whilst surgery is ongoing, the patient will be resuscitated by the anaesthetist or intensivist, and this does require a multidisciplinary approach to save the patient's life. What is the mortality rate? It's high, something in the region of 25%, maybe even slightly higher, even with treatment. The mortality for gas gangrene, the subgroup of necrotizing soft tissue infection, is even higher. It can be over 50%. And this may be treated with primary amputation in order to save life. So what are the consequences of necrotizing fasciitis? Even if you do survive, remember that you've had an extensive soft tissue debridement. Patients often end up with vast areas of denuded tissues. And once the infection has been cleared, which often takes several trips to theatre, these defects will need coverage. Our plastic surgical colleagues tend to get involved at this stage to perform skin grafts or flaps. You can imagine how losing all the skin around the perineal region in Fournier's gangrene can be a recipe for disaster, as these open wounds can continually be infected. These patients may undergo a diverting colostomy in order to reduce this risk. So as you can see, this condition does require specialist input from members of a multidisciplinary team. And as we learned before, death is a very real prospect from this condition. So it's important to inform family members about this at the early stage. To conclude, necrotizing fasciitis is a clinical emergency. It requires immediate treatment with high-dose, broad-spectrum antibiotics, as well as rapid surgical debridements and resuscitation by the multidisciplinary team. Thank you.